We are in Chicago for ASH Clinical News. We're talking about a randomized phase 3 PERSIST-1 trial, and it's evaluating the investigational agent Pacritinib in patients with myelofibrosis. And I'm with Dr. Ruben Mesa, Chair of Hematology at the Mayo Clinic Cancer Center in Scottsdale. Let's begin with the setting, myelofibrosis. Talk about it for a second.
Well, myelofibrosis is a debilitating myeloproliferative neoplasm. It clearly can lead to a lot of morbidity as well as early mortality in patients who are afflicted. It's about 20,000 patients in the U.S. Currently, there's only one FDA-approved therapy, which is ruxolitinib, or known as Jakafi, agent that has been helpful for improving splenomegaly and symptoms in patients with myelofibrosis, potentially even survival, but has had limitations in terms of cytopenias. So that's kind of the unmet needs around some of the clinical aspects of myelofibrosis.
Now, in this case, Pacritinib is a next-generation JAK2 FLT3 inhibitor, correct?
Correct. So a little different kinase profile than ruxolitinib, the approved agent. It inhibits JAK2 in a very specific way. Some preclinical data to suggest there may be even some specificity for the mutated JAK2, which is present in patients with myeloproliferative neoplasms, as well as hitting FLT3, leading to some parallel investigations in acute leukemia and other FLT3-containing malignancies.
So given its kinase profile, what are the potential areas where this may be evaluated? Then we'll talk about the trial specifically, but where are we being evaluating this drug?
Sure. Well, in addition to myelofibrosis, the other myeloproliferative neoplasms, particularly polycythemia vera, is of interest. As I mentioned, with FLT3, acute leukemia is of interest, as well as patients with overlap syndromes between myeloproliferative neoplasms and MDS. In addition, as are being discussed at this meeting here as well, there are many solid tumor areas where inhibition of JAK2 may be of benefit in pancreatic cancer, breast cancer, and several other areas that are being explored.
Now, in the case of the PERSIST-1 trial, talk about the patients first and then what you're reporting here.
Sure. So the eligible patients were patients with intermediate and high-risk myelofibrosis. They clearly had a burden of disease with splenomegaly. The distinguishing characteristic of this study is that patients had no limitations on pre-existing platelet counts for entering the study. One of the limitations of our currently FDA-approved therapy of ruxolitinib is it's indicated in patients with a platelet count above 50. There are many patients with very advanced disease that have significant thrombocytopenia. Why that's a limitation with ruxolitinib is that the drug can cause thrombocytopenia, so it is a limiter. So the phase 3 study is built on the earlier studies which found Pacritinib was safe to be given in individuals with very low platelet counts or significant anemia, and even have the potential to potentially improve baseline cytopenias in patients. So all patients intermediate and high risk, irregardless of their counts, were eligible, and then they were randomized in a 2-to-1 fashion between Pacritinib at 400 a day or best alternative therapy.
And what did you find?
What we found is that the drug was, one, it was very significantly active as we had expected. It helped to improve splenomegaly, helped to improve symptoms, and was vastly superior to best alternative therapy. When we looked at the population that was of particular interest, those that had pre-existing thrombocytopenia, platelets of less than 50 or 50 to 100, we found that the difference in efficacy as judged by reduction in splenomegaly, improvement of symptoms, was very, very significant. And there were really no responders in the BAT arm, where we saw very significant responses in the patients with the Pacritinib. We also saw that the drug was safe in this group. There was not any evidence of hemorrhage or other hematologic toxicities. Additionally, we observed that cytopenias sometimes could even improve. We saw individuals with baseline thrombocytopenia have improvement in some cases, and we saw about 25% of patients who entered the study with transfusion dependence for red cells become transfusion independent. So really an incremental benefit potentially over our current landscape with maintaining improvement in splenomegaly and symptoms, which has been shown across the JAK2 inhibitor class, but this incremental benefit of improvement in cytopenias.
So what's next after this?
Well, in parallel, there is a second phase 3 that is ongoing that is called the PERSIST-2 study. That is specifically only for patients with thrombocytopenia, but is a second-line study for individuals who have previously had another JAK2 inhibitor, either ruxolitinib or another investigational JAK inhibitor, or multiple JAK inhibitors. So both of these sets of data really will be combined to try to best define, what are the groups of patients who would be ideal if pacritinib was commercially available.
Terrific. Well, for ASH Clinical News, we are here in Chicago.